At the American Heart Association, we believe that every person deserves the opportunity to live a full, healthy life. In our quest for a world of longer, healthier lives, we have prioritized communities where we see the poorest health metrics and outcomes. North Philadelphia is one of those communities. With a life expectancy of nearly 20 years less than those living in Center City, as well as limited access to healthy foods and affordable housing, it is critical that healthcare professionals caring for residents in historically under-resourced neighborhoods have a full understanding of the challenges their patients face. Dr. Crabb, you possess an unwavering commitment to improving and extending lives by not only addressing health, but understanding the social influencers that play a grave role in one's ability to live a long, healthy life. I am so proud to be here with you today so we can all begin to better understand your patients, the community you serve, and the challenges they face daily. Dr. Crabb, welcome to today's conversation. I want to go ahead and jump right in because I know we're all really excited to hear from you. You have been at Temple, which is situated in the heart of North Philadelphia, for a number of years now. Can you talk a little bit about what inspired you to dedicate your life to this work?
Well, thanks, Jennifer, for asking for an interview. That's a big question. I mean, when I was a fellow, I got interested in women's health. Because I heard about the mortality differences for women, particularly African Americans, after heart attacks. And then I got the opportunity to come to Temple, which was a big big university. And I said, oh, well, this would be an opportunity to study that. And so I wanted to be in a place where there were underserved women and that I get a chance to deal with health disparities and sex-specific disparities in cardiovascular disease.
You know, having been in the field for so many years, I'm sure you've seen a number of changes over the course of those years. What can you tell me about those changes that you've seen, both within the clinical care setting, but also outside the clinical walls and in the community for your patient population?
Well, I think, I've been privileged to be a cardiologist and a physician long enough to see a lot of major medical changes in cardiac care. When I was a fellow, ACE inhibitor, which is hard to believe, ACE inhibitors were not yet standard of care when I was a medical resident. So I lived through that whole vetting process and getting ACE inhibitors as a treatment for heart failure. I've also seen the beta blockers come into fruition, as well as the advent of stents, which I think have been, major accomplishments from the medical community on the care of cardiovascular patients. But in the community, I have to say that there hasn't been as many interventions as I would like to see in the community. And so I think that although we have a lot of great medicines and a great therapeutics for patients, we still have a ways to go to bring the community into understanding the impact of these interventions that we do on their behalf and the importance of the medications that we've developed to take care of their heart disease.
So nutrition is a real key component of managing cardiovascular disease, both on the prevention side, but also after diagnosis. And as we think about the neighborhood of, within the neighborhoods within North Philadelphia, we've heard the term food deserts, and we've heard the term food swamps. And so is it a matter of whether or not people want to make the right choice, or are they able to make the right choice?
So this is a very big pet peeve of mine. Every cardiologist has been trained that, if you have high blood pressure or if you have certain other cardiovascular conditions, we go through the mantra of lifestyle modifications, restrictions of salt, and other types of dietary restrictions. Yet the people that I care for really have a hard time complying with that because they have a hard time finding healthy fruit and vegetables. They have a hard time finding low sodium choices, and the healthier foods tend to be more expensive. So they're not readily available. So here we are telling them, eat less salt, exercise more, and they live in an environment which does not produce a conducive, overall environment for them to achieve those goals. And so it's very frustrating and very difficult sometimes to add that secondary component onto their care, which means that all you're really doing is giving meds. And the meds are good, but they're not the whole package. People do well because they buy into the package.
Dr. Crabb, I'd love to close out by hearing sort of what are some of the bright spots that you're seeing in your work, and what are you most proud of?
Well, I'm really excited about the work I'm doing now. I've been very blessed to be a recipient of a PCORI award, and we're working on developing a research agenda and a research set of priorities for COVID-19 and racial disparities in both in cardiovascular health, as well as sex-specific disparities in cardiovascular health around COVID-19. And I think the work that we're going to be doing here is going to be very important. It's a project that allows us to expand beyond the work that I did with the community on heart health education, mostly around women's health. But it will allow us to get the community involved in understanding the importance of research, the development, and the innovation of cardiovascular disease, specifically around, health disparities. COVID-19 is the health disparities problem of the 21st century. It is what uncovered, these long-standing disparities and really have put them at the forefront of our concern. And now really is, I think, going to be the driving force for us innovating and trying to get better solutions to this problem.
Well, congratulations on that prestigious award. COVID-19 has certainly amplified a lot of underlying challenges that have been there for centuries. And so congratulations and thank you for your good work.
Thank you.
Thank you for being here today.
Thank you for the invitation.
In 1924, a group of 6 pioneering cardiologists gathered to better understand heart disease. In those days, people diagnosed with heart disease were destined to complete bed rest or to imminent death. Believing that scientific research could lead the way to better treatment, prevention, and ultimately a cure, the American Heart Association was formed. The advances in diagnosing and treating cardiovascular diseases since then has dramatically improved, and there are many successes to share. But what those 6 pioneer physicians didn't plan on back in 1924 was the question, why are some people living in some neighborhoods living longer than others?
Life expectancy is the largest disparity that we see in our city. When you are in Center City, people are living a long, healthy life of 88 years. If you travel 3 miles north up Broad Street, we're seeing that drop dramatically to 68 years.
Philadelphia has a higher rate of premature death from cardiovascular disease than any other large city in the United States. Heart disease, chronic illness, and poor quality of life disproportionately impact low-income and minority populations in Philadelphia due to the social influencers of health.
Hello, good afternoon, everyone. My name is Dwayne Wharton. I'm the co-founder and senior advisor for Just Strategies. We're a social mission-driven consulting firm, but I'm also a long-term volunteer of the American Heart Association and a local AHA board member. With death rates from heart disease and stroke, they've declined overall over the years. Across America over the past 2 decades, communities of color and rural communities, unfortunately, don't share in those gains. The COVID-19 pandemic has shown us that structural racism plays out in such a way that families of color are disproportionately losing their lives and livelihoods to this crisis. But even before COVID, Black people have been experiencing a nearly 30% higher death rate from heart disease and a 45% higher death rate from stroke compared to white people. Recently, the American Heart Association pledged to fight racial disparities in heart health and boost the life expectancy of all Americans through a multi-pronged effort to combat structural racism, starting with an internal review of its own policies and the research it promotes. I'm honored to be here today to lead this important discussion focused on pathways to achieving health equity. A strategy rooted in equity, number one, looks at the problem with a historic and structural lens. Number two, engages people who are most impacted and closest to those issues to inform those solutions. And three, is intentional about targeting resources where they're most needed. It takes recognizing and acknowledging both the assets and challenges within our communities to be informed by the communities and mobilize alongside members of those communities to address issues and invest in community-driven solutions. And in doing so, AHA may look different than it has over the past 96 years. See, through science, we now understand better how health is determined by issues like the lack of access to healthy foods and quality healthcare, housing, and education. And AHA is in a unique position to not only address those immediate needs surfacing and being exacerbated by the COVID-19 pandemic, but also to influence lasting change by addressing those root causes. And that's what we're here to talk with you about today. I'm pleased to be able to introduce you to a panel of fine speakers. We have Atif Bostic, who is the Executive Director of Uplift Solutions, and he's also a Southeastern Pennsylvania AHA board member. Hello, Atif. We have Dr. Bill Gray. He's the System Chief of Division for Cardiovascular Disease for Mainline Health, and he's also the President of Lincoln All Heart Institute and a board member of the Southeastern Pennsylvania AHA. And then we have Raymond Guthrie, who's the Managing Director of the Bernard J. Tyson Fund and the AHA Social Impact Fund. So thank you, panelists. Let's start with you, Dr. Gray. You know, as president of the local AHA board and long-term volunteer, can you help us make sense of the evidence that has led AHA to where we are today, and also what populations are most impacted by high blood pressure, heart disease, stroke, and other chronic conditions, and even why?
Of course, Dwayne, thank you. And it's really an honor to be part of this panel and this important discussion. You know, as the American Heart Association sets out on their 2020 impact goal, which was to decrease mortality from heart disease and stroke by 20% and improve the health of all Americans by 20%, we monitored key prevention indicators, which included hypertension, an unhealthy weight status, and smoking status. These key indicators and overall cardiovascular outcomes showed correlation to lower economic status, lower educational levels and education, income, and occupation. These trends made it clear to us that the need to address health impact through the conditions in which people live, work, play, and pray, and led us to our presidential advisory in 2015, stating that social determinants, the circumstances in which people were born, grow, live, work, and age, are fundamental causes of cardiovascular health that can occur over a lifetime, and the failure to address them will compromise the AHA's goal to decrease cardiovascular mortality and improve ideal cardiovascular health. So to answer your question about disproportionately impacted populations, I'll use Philadelphia as an example. In Philadelphia, as you heard from Jennifer, we see not only disparities based on zip code, but also based on race and ethnicity. The Black and Hispanic Latino populations in Philadelphia, in them, we see significantly higher rates of smoking, sugary drink consumption, and consumption of foods high in sodium and saturated fats. And these health behaviors result in hypertension, type 2 diabetes, and can ultimately lead to heart disease and stroke. I want to make it clear that these health-related decisions are often not made by choice, but are determined by a lack of access to opportunity to make healthy choices. Neighborhoods in North and West Philadelphia are adversely impacted by the lack of access to healthy foods, by unhealthy housing conditions and other social determinants of health. These factors, on top of the daily stressors of stressors and trauma experienced in these neighborhoods, have led the AHA to give special attention to these populations living in these parts of the city. I also want to acknowledge that the Black and Hispanic Latino populations are more likely to experience hospitalizations due to complications related to the coronavirus. And the health impact will not only be felt in the present moment, but the economic impact caused by the pandemic may also result in even more unfavorable health outcomes in the future if we don't address these social determinants of health now and today. Thank you. You're on mute.
When you're on mute.
Of course I am. Yeah, thank you. I really appreciate you elevating the notion about choice. So the CDC has a health impact pyramid. And at the very top of that pyramid, they look at where there's the most impact for improving health, and at the bottom, the most opportunity. And at the very tip of that, where there's the least amount of impact, is this notion around personal choice and personal behavior and telling people to eat healthy and to exercise. And if you move down that pyramid to have an increased health impact, you look at policies like fluoride in the water, and we look at clinical interventions like folks like you and cardiologists can write prescriptions and can actually provide more clinical support to them. As you go down the pyramid, you see policies like smoking bans and soda taxes. And at the very base of that, we look at poverty and housing and education as the largest influences of health and how we really need to move the needle by addressing those issues. So thank you for reinforcing that. Atif, I know that you spend a lot of time working around the social determinants of health. Can you dive a little bit deeper into talking about these determinants, and how does your work to address them?
Absolutely. Thank you, Dwayne. And thank you for allowing me to be here and have this conversation. I'll go back and start by pointing back to what Dr. Gray talked about, specifically, related to the social determinants of health. And I think he did a great job in really identifying what they were. And when I think about that, the two that stand out most to me are around social environment and physical environment. And the other things that roll up to that would also include, access to healthcare, access to jobs, and things like that, as it relates to that. So if we were to dive a little deeper and we think about it, particularly in the context of the report that was just released by the American Heart Association, which Dr. Gray referenced, and you may have referenced as well, Dwayne, around structural racism. This leads back to the convention of 1787, when Black people were deemed to be 1/5 of a person. And you think about how that carries through in the context of where we are today, and you think about more recent practices such as redlining, where banks wouldn't lend into certain neighborhoods. You think about the Flexner report that was published in 1910, where it led to closure to 5 medical schools that trained Black doctors or Black physicians. And, you think about the access to healthcare there. And so, as I think about this context and I think about social determinants of health, I think it's really clear when we look at the context, right? The historical context of this, how it leads to where we are today.
Yeah, thank you for that. Again, you brought up some excellent points, and I think, you and I have both worked in the food access space, and, we look at this practice of redlining, and again, it's the literal writing off of communities based on who lives there. And if you have people of color living in those communities, you have a less favorable rating than you would for white communities. It led to white flight and in the de-investment in urban centers. If you operated a grocery store in those communities, you're less likely able to, get a loan and to have higher insurance rates, et cetera, which contributed to folks moving to the suburbs simply to have better business opportunities. But it left in its place this void of healthy food access for communities. And again, like your work in Uplift does a lot to try to address that. But that's how like structural racism plays out. And we look at choices being made in communities and why folks don't eat healthy when the grocery stores have left a long time ago and people are left to eat at corner stores, which don't offer the same variety and certainly not for the same price and quality. So I really appreciate the work that you're doing.
Great, thank you.
So Raymond, I know that you have spent a lot of time in your career working and investing in community transformation. Can you talk about the role that community investment plays in transforming communities through innovation, and especially given the pandemic and the economic downturn that we're seeing as a result of the pandemic?
Yeah, absolutely. So as you just laid out, the lending habits and the funding habits of institutions have led to companies and organizations having to leave certain parts of the community to have better business opportunities. What community investments funds like ours are focused on is actually redirecting resources to organizations and companies and people that are reflective of the community, but also have a felt understanding of the community, so that the best organizations and the best groups, just like TIEFS groups, are funded so that they can actually have the resources to drive change. So the best community investment funds, in my view, aren't the groups that have an idea that want to push on the community, but instead listen to the community and understand from them where there are opportunities. So not looking at Northern Philly as a place of need, but instead of a place of opportunity for groups that have great ideas that have been simply overlooked and underfunded. And what our fund tries to do is provide the right resources, both in terms of capital, but also the support they need to get their ideas and their businesses to drive. So the way our community funding drives transformation is by enabling people like a TIEF, like great entrepreneurs, the resources and the support that they need to drive change, but not actually doing the change ourselves. So the listening and supporting growth from within.
Yeah, thank you for that. So, I've been a volunteer with AHA for many years and have partnered with them in many different ways. And as we are talking about kind of this different approach and like things like the Social Impact Fund, for some folks, they don't quite get it. Like they don't understand necessarily how it's different now versus how AHA has traditionally been. Can you speak more about the Social Impact Fund and how is it different than other community investment models and how traditionally people have thought about the work that AHA has done, specifically as it relates to addressing these root causes of health inequities?
Yeah, absolutely. So if you look historically at traditional philanthropy, less than 8% of all traditional philanthropy goes to minority-led organizations or even targeted groups or communities that are disproportionately African-American or Hispanic. If you look at traditional venture capitalism, less than 1% of all venture capital last year and the years before that have gone to organizations led by Black or Hispanic entrepreneurs. So right there you have institutions and funding streams that are historically overlooking and underfunding people that are disproportionately representative of the communities that have health disparities, right? And so what's different about the fund is that we make a concerted effort to invest in people from those communities that are reflective of the communities, but also have a felt need. And at the same time, our fund doesn't just have a one-stop shop of what we support. So we don't only support we not only support nonprofits, but we support for-profits. We not only provide grants, but we also provide debt capital and convertible capital so that we look for the best ideas and entrepreneurs that have them, and then provide the resources that they need. So our forum matches the entrepreneurs as opposed to forcing organizations to fit into a certain structure or a certain needs. The other thing is that it's not, our funding doesn't go to the person that has the best connections or writes the best proposal. Instead, our funding goes for the organization that has the best understanding of the community and best ties to the community and actually has the best idea. In the traditional sense, the people that write the best proposals, the people that have the ability to get into the room are the ones that get funding. Our funding also is, the last part that's different about us, is that we invest in the social determinants, but understanding that they're all interconnected. We build a portfolio of solutions by the community for those different social determinants that collectively drive towards this North Star of health equity. So that's really how we're different. We're funding the people that are overlooked and underfunded. We're providing resources that are flexible to and responsive to their needs. And then we're still staying true to what the AHA focuses on, which is evidence and finding and driving measurable outcomes.
Okay, yeah, thank you for that, Raymond. For anyone who just joined us, I'm here with Atif Bostic, who's Executive Director of Uplift Solutions and a board member of AHA here in Philadelphia. We have Dr. Bill Gray, who's Assistant Chief of Division for Cardiovascular Disease for Mainline Health, and also President of Lincoln Heart Institute, and also a board member, and Raymond Guthrie, who's the Managing Director of the Bernard J. Tyson Fund and AHA Social Impact Fund. If you have any questions for any of these panelists, and even for me, please drop them in the chat. We really want this to be as interactive as possible. So we encourage you. We've seen a lot of people shouting out Dr. Crabb and others, but we really want to hear from you. So anything that comes to mind as we're having this conversation, we encourage you to share and we'll try to answer it. Getting back to you, Dr. Gray, we know you oversee Lincoln All Heart Institute, which serves a very diverse group of patients, and you also see the end result of health inequities, which is too often, heart disease and poor quality of life and shortened life expectancy. And on top of that, these same patients are faced with more adverse outcomes from coronavirus. Can you speak to anything additional that you're seeing as a key driver of health inequities that we haven't maybe touched on so far?
Thanks, Dwayne. Yeah, we do serve a very diverse community. We have Mainline, which is a pretty well-heeled community to our west, and West Philadelphia to our east. And so we see the differences in access to healthcare, health education, literacy, access to healthy food choices. One of the things that happens because of issues around health literacy is that, and access to healthcare, frankly, is that we see a lot of patients coming to the emergency room as their primary source of medical care. And that's obviously not what we want to see, because that means that they're at the end of a long disease process that probably could have been interrupted in a meaningful way before they came to our emergency room. And we've just kind of to touch on that for a moment, we've worked at Mainline Health and with the Lincoln Heart Institute, along with the AHA, to build community clinical linkages. That is, reach out into the community to trusted sources there to really address issues around health access, education, and literacy. That's an important community effort because it really addresses the core issues that we see in our emergency rooms regularly. And I want to boil that down for our audience to a very concrete example, which is hypertension. We all know that treating hypertension can reduce stroke, heart attack, kidney failure, and heart failure. And we treat hypertension aggressively. And even in the best of circumstances, people don't comply with their blood pressure medications or don't get controlled probably about 50 or 60% of the time. So that's in the best ideal circumstances. Imagine going to an underserved community where they don't have access to clinical care, they don't have healthy food choices, they can't get medication, they don't get educated on the importance of hypertension. So what happens is they show up in the emergency room with any one of those problems. They come in with hypertension related kidney failure, and they're then dedicated to renal, dialysis for the rest of their lives. Something that could have clearly been avoided had they been able to address the hypertension earlier in their lives in a more aggressive way. These are real people we see on a daily basis that we need help with in terms of getting them the access to medical care, the literacy for medical care, and better access to food choices. The AHA also works alongside primary care providers within health systems like ours in the Mainline Health and federally qualified health centers to improve standards of care and to expand patient education and address these barriers that are caused by the social determinants of health. And the example I just gave you is a really very meaningful one. The AHA has also prioritized evidence-based concept of patients self-monitoring blood pressure from home and to assist with the accurate diagnosis and management of hypertension. And this will go a long way because the ripple effect of just something as simple and straightforward as hypertension control is not just for the patient, but for their family and for their community is very, very meaningful. In addition to the work in the community that we do and in clinical settings, the AHA also advocates for longer-term solutions like expanding health plan coverage for blood pressure cuffs, and works further upstream by collaborating with city governments and large employers in food industry to limit sodium content in foods. And the sugary drinks is a good example of where we've been able to do that on the obesity and diabetes side of the equation. So we've already made we've had some wins. There are many more. It's a fertile ground for improvement. And I think this call and things and activities like this are critically important to moving this forward.
Yeah, thank you for that. Yeah, there's no shortage of opportunities for sure. So thank you. Atif, I know that you are also active with AHA National. You serve on the National Diversity Leadership Committee. I think you're having similar conversations to what we're talking about as well. Can you speak to some of the efforts you're helping to lead through this committee and how it's impacting AHA's work?
Yeah, absolutely. And I'm excited about the work. And what I'll start with is really the focus of the AHA at a national level to really look at the social determinants of health, right? So, for a long time, the AHA has been focused around cardiovascular disease, neuro disease, and so stroke, heart attack, and looking at the clinical aspects of those. And so there's been a movement, particularly in the last several years, around focusing more on the social determinants of health. So from the committee that I sit on, the Diversity Leadership Committee, there's a number of things that are going on there. Number one, really taking a hard look at the communities that we're talking about today, those underserved communities, communities of Black and Brown people that are impacted adversely, with access to fresh and healthy food, access to healthcare, just like Dr. Gray just spoke about. And so, coming out of that really is this heightened focus on the social determinants, and continue to look at that and look at new ways to address those. The other work coming out of that, the Social Impact Fund, that's a great example of, one of those things that came out of the work of the Diversity Leadership Committee over the last several years. And there's also work going on right now around addressing food deserts within the AHA, and how the AHA can actually play a role in bringing more supermarkets online and access points for fresh and healthy food. So there are a number of things that we're looking at. I would also say that, as we look at it, as far as a cultural context, is that the Diversity Leadership Committee is almost also a kind of clearing area for ideas as they come through the AHA, to make sure that we are looking at them through a diversity lens, to make sure that all communities benefit from it as well. So I'm excited to also serve on the National Diversity Leadership Committee as well.
Yeah, that's awesome. Thanks, Ati. And for those who are on the call, you are probably aware that today is Giving Tuesday. And that really does kick off the season of giving to nonprofits. And, Raymond, as the AHA staff representative on the panel, anything that you want to add maybe for our audience today related to Giving Tuesday?
Yeah, absolutely. Like many other organizations, for-profit and nonprofit, the American Association has not been immune to the economic impact of the global pandemic. Yet our mission is now more important than ever. And so we're incredibly grateful for our longstanding and dedicated volunteers and supporters for standing beside us during these challenging times. Our work is only made possible because of your generosity. And if you're in a position to offer your support during the season of giving, we hope that you will consider supporting the American Heart Association. With your support, our work to ensure equitable health and opportunity for all can move forward and continue. So I thank you for spending time listening to us, but also considering supporting us further.
Yep, thanks, Raymond. And we had a question in the chat for you specifically. They were asking, what's a specific example of an investment that AHA has made through the fund?
Yeah, actually, we made an investment in an organization called Ride Health that actually was started by a young man that was at Penn University, actually. And though our investment is supporting their work in New York, they actually have a work going on in the Philadelphia area. And what the group does is essentially, a lot of hospital systems provide free transportation to low-income patients so that they can come to the hospital for non-medical emergencies or non-medical care or follow-up visits. But often the management and utilization of these free transportation vouchers is actually very difficult. And transportation is a big barrier for access to healthcare. This group did is created an online or an app essentially that allows the management of the online transportation for the hospitals. It takes it out of their hands and manages it for them so that they actually increase the amount of low income and patients without transportation to actually utilize these vouchers and increase the amount of people going to follow-up care. What's interesting is that during the pandemic, as transportation becomes even more challenging, their ability to navigate and find the right transportation groups, either it's Uber or it could be like professional drivers, has become more important. But actually, they've also been able to provide distribution of food to food insecure residents that are receiving food supplements from the hospital system. And even more recently, they actually are now providing the transportation services to the people that are participating in the vaccine trials. So this is an example of us at the AHA investing in a core challenge, right? Transportation. We provided grant support, but this is actually a for-profit entrepreneur. But our grant support enabled them to start working with more people in Medicaid systems and other Medicaid providers, so that more low-income patients can actually receive their services, and more services can be leveraged on top of their transportation.
Yeah, that's an excellent example, and I particularly love that there's been innovation in the model, starting from transporting to hospitals for clinical care, to adding the food access, and now you're mentioning again access related to COVID vaccination. Folks who are experiencing poor health outcomes have lots of barriers that oftentimes layer on top of each other, as Dr. Gray was talking about. So I love the nimbleness and the innovation that's building upon this investment. Can you speak to the size of the investment that was made at all?
Yeah, actually, we gave them a $250,000 one-year grant to start with. They're going to probably end up raising equity in the next year, and we'll actually participate in that most likely at a larger scale. So once again, demonstrating we could provide grants, but then we also provide for-profit investments as well too, and our flexible model enables us to participate on both sides.
Right, and that $250,000 came from a fund, and it came from being seeded by individual donors, larger donors, or a combination.
Right. So we funded that group out of the AHA Social Impact Fund, which was started by an initial $5 million investment from an individual. And I'm happy to say, when I joined the AHA, we had about $5 million invest. We're up to about now $21 million in investment capital across the country. And we'll be soon investing actually in Philadelphia in the coming months.
Yeah, we're excited about bringing it to Philly. So thank you. Dr. Gray, I'll give the final word to you. So as the president of the local board, how would you encourage our viewers to take action to move this important work forward?
Thanks, Dwayne. First, let me say that I'm honored and humbled to be on this call with you, Dwayne, Atif, and Raymond. I'm absolutely blown away by the work that you do. And I think our viewers can see that this is not just a named fund. This is well thought out, nuanced approach to real macro issues that are being addressed at a micro level. And this is critically important, and I can't stress that enough. I want to encourage you to continue to lend your time and expertise to advancing the mission of the AHA. I know that Raymond and the local AHA team are working hard to identify funders to jumpstart the Social Impact Fund here in Philadelphia. So I encourage anyone in a position to make a significant contribution and interested in learning more to connect with a local AHA staff partner. Otherwise, I mean, as we continue to work relentlessly to create a world of longer, healthier lives, which is the AHA mission, a full mission gift to the American Heart Association at any level can impact lives and communities across the nation, around the world, but the scope and influence will also be seen right here in the greater Philadelphia area. Your gift can help support all of the initiatives you've had a chance and the opportunity to learn about today, including advancing science and research, improving nutrition security, quality improvement programs, in clinical settings like here at Mainland Health and other institutions in the city. Your support can help sustain and grow this life-saving network. Your generosity can also act as an amplifier to inspire others to give this holiday season as we work to pay it forward to help those who may not be so fortunate. To make your year-end gift, please text AHA Philly to 41444 and follow the prompts from there. Dwayne, I hand it back off to you, and thanks again for putting this together and doing such important work.
Yeah, thank you. Yeah, thank you, Dr. Gray, Atif, and Raymond for joining me and having this discussion today. And especially thank you to the AHA volunteers and supporters who have taken time out of the day to join us as well. So with that, you have on the screen an easy way to make a gift to AHA. We thank you for taking the time to be with us, and we wish you happy holidays. Please be well and stay safe.